دكتور عماد share.
Just well, give me 1 second يا نواف. I'm just discovering this thing. Okay. Oh, I share screen. Okay, that's why. Layout. Here. Assalamu alaikum. Okay, our dear guest, do you actually listen? Can you hear me now? Everyone. Okay, so guest, can you actually see us right now? Yeah. Okay. Oh, that's weird. Oh yeah. So I'm trying to work on the video. Can you stop share? FaceTime. Okay. All right. So, well, first of all, I'm just gonna try to show my picture, and then I will just start our program. The only issue we have right now is because we chose to do a webinar. That's why we are not really. Our team, can you stop sharing the screen? Yes. Can you see my picture now? Okay, there we go. You see me now. All right, so I would like to welcome you all at our almost fourth Endo Orbit session. Basically, this time is focusing on biliary pathologies, the challenging ones, whether they are related to stones or actually indeterminate strictures. Now, I just want to confirm if you can see us. Can you see the video? Can you see the screen before I proceed any further? Okay, so I don't know what. Okay. View. Is this gonna be? Okay. Oh, I see. Yes. Let me just see one thing. Okay, I'm not sure why I'm not gonna be displayed. Can you see? Still, you cannot see me. All right. I'm just working in this glitch. Hopefully, we're gonna fix it right now. Okay. Okay. Now this share. I want to stop this share. Can you see me now? Can you see me now? Oh, that's very okay. I think I know what's the problem. You should see me now. No? That's very interesting. Spotlight. My apologies for not being able to see you guys all. All right, now it seems like we are live. All right, thank you so much. So again, I'm sorry for that little glitch that happened at the beginning, and the only reason for this is basically we have changed our regular Zoom meetings to webinars so we can accommodate more people and also to be more interactive with our audience. So as I explained at the beginning, we're going to start today or discuss today the fourth Endo Orbit session after the successful series of Endo Orbit education. We're going to talk more specifically about biliary pathologies, including stones and how to manage these large complex stones, as well as biliary strictures, specifically the indeterminate ones, and the rules of cholangioscopies and advanced equipment. So we are so pleased to have our two guest star speakers, Dr. Ibrahim Balbaid and Dr. Nawaf Muteri, which are well-known figures in our field within the kingdom. And first, we're going to start with Dr. Nawaf, who is actually going to give us a talk about the management of challenging or complex stones. I welcome Dr. Nawaf. And in that case, I will give you the option to share your screen, Dr. Nawaf. Please, if you could do that. Dr. Nawaf.
Assalamu alaikum.
Salam.
All. Thank Dr. Imad and Endo Orbit team for giving me this opportunity, and it's really my pleasure. So I hope my slide is clear.
We are trying to make it. Just give me 1 second. Can you open the video by any chance? Yeah, like your video on the screen, I cannot see it yet.
I can't mention you can't do it.
Sharing screen. Dr. Nawaf.
Yes. Still?
Let me just. Okay. Okay. Dr. Nawaf, we're trying to get you on. I'm trying to solve it with the team. Okay, no, I don't think so. Don't think that's the case. You're supposed to be able host that. Okay, now I think you can. Sorry, that was a little thing we learned about webinar. Please do share your screen. Dr. Nawaf?
Yes.
Okay, there we go. I think we just make it bigger, please.
Okay.
There we go.
It's clear now.
I think everybody sees your screen. You can go ahead.
So first, we're going to talk about the biliary stone. This is my conflict of interest. So EDA is advisor, border, and Pfizer is supporting for lecturing. So first, we have to talk about natural history of the gallstone. You know, the gallstone prevalence, it's 10 to 20% in the population. But fortunately, it's only 10% they developed a symptom, and kind of symptom, it could be an acute cholecystitis or biliary colic. And the risk of developing bile stone is 1 to 2% per year. And bile duct stone developed, the patient had a risk for pancreatitis, cholangitis, and jaundice. So the gallstone classified into the cholesterol or bilirubin stones, and risk to develop a gallstone usually is a female sex, age, pregnancy, and physical inactivity, obesity, over nutrition. And we noticed the gallstone is running in some family. So the reason behind that one is a common mutation in hepatic cholesterol transport ABCG8, which is responsible to develop the 25% of this family. So the predictor of the CP2 stone, it's well known, and it has been published in ASG and ESG. And we know there is a very strong indication to go for ERCP, presence of CBD stone in ultrasound, or patient have a clinical ascending cholangitis or bilirubin more than 4. So we know ultrasound in the CT, it's very low sensitive to detect stone, but it's high specific. If there is a stone, there is no doubt about that. And we know there's a 6% of patient, they have a CBD stone, but normal ultrasound and normal LFT. So in this situation, you have to go for EUS or MRCP. So in our center, we implemented using an EUS before doing an ERCP to make sure this patient is really indicated to go for ERCP. So the extraction of CBD stone, we have a standard technique, which is considered as easy, and 85% to 95% of patient they required the standard technique. But unfortunately, it's 10 to 15 of the patient, they have a very difficult CBD stone and they require advanced technique or complex technique. So before doing an ERCP, you have to be good in mastering the cholangiogram interpretation. So to have a maximize cholangiogram interpretation, a patient position is a matter, and it's considered as one of the quality indicator in ERCP. So better position, patient has to be in the prone position, better for your scope position, and good for interpretation. And also, we have to keep in your mind anatomical variation of bile duct. So there is a 5 or 6 type of anatomical variation you should understand to give a good interpretation. And do not forget the mimicker. So always think about other pathology rather than stone. As we see in this cholangiogram, we found a filling defect. We tried to remove it by balloon extraction, but that was not able to move. Then we decided to go for cholangiogram, and which showed mass in a biopsy confirm cholangiocarcinoma. So not every filling defect is the stone. So the next step in stone management is sphincterotomy. So the size of sphincterotomy is really matter. So there is a landmark to go for sphincterotomy is the top of infundibulum and able to passage of bended sphincterotomy. So there is 3 kind: small incision sphincterotomy, which could go to the upper fold, medium size, and large incision. So if you decide to remove the stone, go for the large if it is smallest than 1 centimeter. If it's large, you have to go for limited one, small or medium, then you can go for large balloon dilatation. So what about endoscopic papillary dilatation? It's alternative to the sphincterotomy if you do not plan to do a sphincterotomy. So it's really preferred in the east area. They prefer to do endoscopic papillary dilatation rather than sphincterotomy. So because it preserved sphincter function and decreased risk of the bleeding, and a very good option for patient with coagulopathy. But unfortunately, there is a risk of pancreatitis, which is 7 versus 3% compared with sphincterotomy. And another problem with this maneuver, it's increased need for mechanical lithotripsy if you plan to do endoscopic papillary dilatation. So an extraction technique, if there is a small stone less than 1 centimeter, you have 2 options, either to go with extraction balloon or extraction basket. So extraction balloon, it's very easy to use. It can go through the wire. There's no risk of impaction, and you can use it for occluded cholangiogram to make sure there's no more stone. Extraction basket, it's always sufficient for the large stone and more efficient for dilated biliary duct and the floating stone, so you can catch the stone. So, so what's the difference based on the study? Is balloon is good or the basket? So there's a recent meta-analysis. It has been published and showed the balloon catheter superior to the basket catheter for complete stone extraction for CBD stone less than 10 millimeter with no significant difference in the rate of the complication. So if the stone is less than 10 millimeter, that's better to go with balloon extraction rather than basket. So we will come to the difficult, the CBD stone. There is a stone-related factor and there is a bile duct-related factor. We know the stone-related factor, it has to be more than a 15 millimeter barrel-shaped stone, number of the stone, impacted stone, or intrahepatic duct stone, which is considered a difficult CBD stone. Bile duct-related factor, it could be angulated bile duct or tapered distal bile duct or sigmoid-shaped bile duct. As we're seeing in this cholangiogram, this patient had a large sigmoid-shaped CBD. So in this difficult CBD stone, you have to go for advanced or complex technique. So what are the complex technique or advanced technique? We have to use it. either limited sphincterotomy, then combined by endoscopic papillary large balloon dilatation, mechanical lithotripsy, or cholangioscopy assist lithotripsy at the end of biliary stenting. So limited sphincterotomy and combined with a large endoscopic papillary dilatation, it's very good maneuver. And many studies, including randomized control trial, has been published, which showing the clearance is reaching up to 89, and some studies reaching to 86. So with rate of the complication up to 720. In comparison with endoscopic sphincterotomy alone. So if you decide to do a limited sphincterotomy followed by the large, it's very good option, and that will help you to reduce the mechanical lithotripsy. And regarding the adverse complication or adverse event, they noticed in most of the study, the rate of pancreatitis is lower, and if you decide to do this maneuver compared to the sphincterotomy alone. So the next maneuver, it's mechanical lithotripsy. So this is a very simple maneuver for fragmented of CBD stone. It's consisting of entrapment of the stone within reinforcement basket, then crushed by closing the basket against the metallic spiral sheet. There is two techniques. You have to do it through the scope or outside the scope. So you have to cut the wire and take your scope out, then push the metal spiral sheet to crush the stone. So study showing the stone clearance is reaching up to 90% mechanical lithotripsy. And the problem, it's require more session. So we know it's effective technique, but main problem, it's requiring the multiple endoscopic session with mechanical lithotripsy. And the rate is reaching 91%, and the complication is 34%. What is the most common complication and third complication? All of endoscopy don't like it, like entrapment of the basket, broken basket, traction, wire fraction, or broken handle. So we remember we have two cases. We did mechanical lithotripsy outside the scope. Unfortunately, the wire has been fractured at the stomach. So the stone was not crushed, and the wire has been remained in the CBD and the proximal end and in the stomach. So then we have a rescue with cholangioscope assist lithotripsy to remove the stone from the basket. Then we're able to remove the basket. So before cholangioscope era, we are sending this patient to the surgery to do a CBD exploration. So what are the predictors for mechanical lithotripsy failure? So we know the stone impaction. If the stone impacted in the CBD, it's difficult to pass the basket. And the other of the stone size is more than a 30 millimeter. This is indicated you will be in a failure in doing mechanical lithotripsy. Or stone to the CBD diameter ratio is more than 1 centimeter, 1 milli, 1. So cholangioscope. This is a very nice cholangioscope. It has been in the market for the last 10 years. And there are three major techniques for cholangioscope. Dual operator, mother-baby cholangioscope system, single operator catheter-based cholangioscope, and direct one, which is using ultra slim scope or slim gastroscope, as we see in the picture in the right corner of the slide. So cholangioscope assists lithotripsy. So once you go inside the common bile duct, you will use a catheter to do an lithotripsy. And we have two kinds of lithotripsy: intraductal shock wave lithotripsy by EHL, or a hydraulic wave, or laser. So both methods are generating shock wave. In EHL, they require continuous saline irrigation. Compared to laser, there is no need for saline irrigation, and there is no need to touch the stone in EHL, but in the laser, you have to touch the stone to fragment the stone. More wall damage we noticed with EHL, and with laser, it's less wall damage. The problem with the EHL, the procedure time is longer, which most of the study, the median is 72 hours, compared to laser, which only is 40 minutes. So the laser, it's on the study showing there's no difference between two modality, but the difference only in the procedure time. So the study showing a very good stone clearance with cholangioscope assisted lithotripsy, even from the first decision. And the study showed the clearance reaching up to 100%. So this is a very good modality, but what the problem with this limitation is the cost. So in our country, we have almost 5 devices. The median price is exceeding $2,000. So as we mentioned, the removal of the bile duct stone ranging from 70 to 81% in the first session, but the second session is reaching 100%. Complication from 0 to 25%. Cholangitis is the most common complication, and the advice recommendation to give antibiotic post cholangioscope. Pancreatitis is rare, but they blame it. The scope sometimes is compressing the pancreatic duct, which can lead to the pancreatitis. And this is in a picture, sorry, for the imaging from the mobile. So which is best for management of the large CBD stone, either sphincterotomy alone, sphincterotomy, limited sphincterotomy with a large balloon, dilatation, mechanical lithotripsy, or single operator cholangioscope. This is a recent meta-analysis published 2013 in the GIA and showing cholangioscope. It's a best with a lithotripsy, is clearing the stone is about 99%, followed by endoscopic balloon large dilatation, then mechanical lithotripsy. So this study is containing 19 randomized control trial. It's more than 2,700 patient and stone more than 10 millimeters. So we understand now the cholangioscope with assist lithotripsy is the best modality, but unfortunately the cost is limitation in this situation. So at the end, temporary stenting placement, it's a must. It's always considered as alternative strategy when approaching the difficult stone. Hypothesis behind putting plastic stent or even metallic stent, it's continuous friction between the stone and the plastic stent that produce mechanical stress and result in the changing of the size of the stone and the number of the stone. So the study showed overall the stone clearance, it was quite low, but at the second ERCP, but still 28% they require mechanical lithotripsy. So long-term complication of stent up to the 50% they will develop cholangitis. So this is an ESG guideline. They recommend if patient has a difficult stone, you have to go for limited sphincterotomy, then endoscopic balloon large dilatation. If failed to extract, you have to consider mechanical lithotripsy or cholangioscopy assist lithotripsy. So conclusion, the patient position is very important. You have to know anatomical variant and mimicker, sphincterotomy size, it's a matter. Sphincteroplasty is alternative. Large CBD stone, you have to go for limited sphincterotomy followed by the large balloon dilatation and cholangioscope. Stent of failure, and do not forget the toll box. Unfortunately, most of the endoscopy, they do not have the toll box, which contain wire cut if you have trapped basket, so we have to cut it. Caesar measurement devices, distal cap, dental floss. This is, it can be used as a tool box. And thank you very much. Bernard, you are on mute.
Oh, thank you, Dr. Nawal, for this great presentation. Can you see me actually? Can you see my picture or my video?
Yes, we do.
Okay, good. So this is a very good point, Dr. Nawaf, and thanks for the great presentation. Actually, I have one question that I would like to share with the audience and see their feedback. And based on that, we're going to get to the discussion before we move to the second talk. So I don't know if you can see the question poll. Is that okay? So now it's on, and the audience can kindly click the answers that they expect. So basically the question has 15 millimeter stone, which is considered complex or big stone as per definitions. 10 millimeter or bigger, and some societies, especially the European, they consider 15 millimeter or larger as complex stone. So would you approach that as the following? You would do just balloon extraction, try to crank it out, or would you perform extended sphincterotomy or large balloon sphincteroplasty, or would you go with lithotripsy, whether it's laser or AHL? So I'm just gonna give another 5 seconds before we have 44 participants in our webinar, and so far 17 has answered the question, and we're gonna allow another 15 seconds before we close the poll and start the answer. Okay, another 10 seconds. Okay, so far we have the majority of the audience actually answered. Most of them actually as they would go, maybe large balloon sphincteroplasty and lithotripsy are almost the same, 33% for each. Less likely to do extended sphincterotomy, and balloon extraction is the second to move to. Dr. Nawaf, what's your take on this? Dr. Nawaf, can you unmute yourself? I think you are on unmute, so you can share perhaps. Dr. Nawaf?
دكتور عماد قط صوتك.
Oh, really? So can you hear me now? Better? No? All right. So, okay, so back. Okay, back to, can you hear me now? Can you hear me now? Okay. Can you hear me now, Nawaf?
Yes, now it's
all
clear.
right. So sorry. So basically, I was asking you, and sorry for these like little things that made our meetings not the best. But anyhow, what's your take on that? Like most, or it's equal actually. Our audience would approach that with large balloon sphincteroplasty. Others would consider lithotripsy. What's your take on this? How would you approach a 15 millimeter stone in the common bile duct?
Yes, the first you have to go, especially if patient has previous sphincterotomy, you have to go with a large balloon dilatation. So the study is going showing a very good stone clearance with large balloon dilatation. So that's first. If you failed to extract the stone, then you can go for lithotripsy, either mechanical lithotripsy or by doing colonoscope assist lithotripsy.
Okay.
But the clue for doing endoscopic balloon dilatation, you have to not exceeding the CBD diameter. Then you have to obliterate the waist. If the waist is not obliterated, probably your dilatation is not effective. So that's the message. So the time between 1 minute or 5 minutes, the study showing there is no difference and doing this time of dilatation.
How about you, Ibrahim? How would you approach this? Dr. Ibrahim? Can you hear me, Dr. Ibrahim?
Yeah, the problem might be with his connection.
Okay, so I would do exactly the same. As a matter of fact, a 15 millimeter balloon, 50 millimeter stone is considered a large complex stone. For these, I would prefer to do either extended sphincterotomy or balloon sphincteroplasty after I make a short sphincterotomy in order to dilate the duct. So the balloon size that you need to go for is exactly the size of the stone or exactly the size of the common bile duct. I wouldn't exceed more than that. And that's to avoid any complications such as perforation. So that's your size of the balloon. And in more complex cases, when that fails, I may consider doing lithotripsy using cholangioscope or even mechanical lithotripsy using the basket. Ibrahim, you're back with us. What's your take on this?
So I agree. I think I would go with the sphincteroplasty before to help to give more like circumference and help to extract the stone.
Okay, perfect. So with that, we have Dr. One of the attendees, actually, Dr. Abbas Gumgumji. So I'm gonna give him the mic for maybe 1 minute, then before we move to the second talk. Dr. Abbas, you can unmute, or you may unmute. Dr. Abbas? Yes. Welcome. Dr. Abbas, can you are on unmute, so you can jump on. I don't know if there's any issues with the connection, so we're going to proceed with the second talk with Dr. Abdurrahim Balbaid. Basically, he is going to give us a talk about biliary strictures. Dr. Ibrahim, welcome for our Endo Orbit session today. Please do share your screen.
Okay, we'll share the screen.
There we go. I think we can see you.
Okay, you see the screen now?
I do see the screen myself, yeah.
Okay, thank you, Ahmad, for the invitation today to present in Endo Orbit. It's my pleasure to present today with Dr. Nawaf discussing challenging biliary pathology. So I'll be talking about the role of ERCP in biliary duct stricture. So this will be the outline for my talk today, and I have no disclosure. So biliary stricture is an abnormal narrowing of the ductal drainage system of the liver. Generally can be divided according to the anatomic location into extrahepatic, perihilar, and intrahepatic. In terms of etiology, there are three main classes: benign, malignant, and indeterminate. Unfortunately, only minority of biliary strictures are benign, about 15 to 24%. So this table showed the differential diagnosis of biliary strictures. Out of the benign etiologies, the iatrogenic, which include a post-cholecystectomy and post-liver transplantation or hepatic resection, is the most common category. While in the malignant types, the pancreatic cancer is the most common cause of distal malignant stricture. So the differential diagnosis, as we know, is broad for biliary stricture, although the historical clue by themselves cannot establish the diagnosis, but at least can help to affect the pretest probability of the choice of diagnostic test. So if you get patient with advanced age, with significant history of weight loss or painless jaundice, make you think of malignancies. If you get a stricture with in a patient with complicated gallbladder surgery or history of liver transplantation, make you think of benign post-surgical etiologies. If you had a patient with inflammatory bowel disease, make you think of primary sclerosing cholangitis. If you get a patient with history of alcohol abuse, make you think of chronic pancreatitis as the cause. And if you get a patient with autoimmune disorders, make you think of autoimmune cholangitis or autoimmune pancreatitis. So bilirubin is one of the standard laboratory tests that can be done in patients with biliary stricture. The greater the level of bilirubin, the more likely the stricture is malignant. This table from a prospective study, including over 1,000 patients assessing the sensitivity and specificity of bilirubin in predicting malignancies. If you see here, if you choose the cutoff of 100, you get sensitivity of 71.9%, while the specificity is 86.9% with likelihood ratio of 5.5. With increasing the cutoff to 250, the sensitivity will go down, but the specificity will go up almost to 100%, 97.1, with likelihood ratio of 11.3. So while standard laboratory tests have a rule, so there are more specific tests like biomarker that can help to predict malignancies, and the most commonly used is the CA19-9. Although there is no agreement on the best threshold for diagnosis of malignancy, the higher the cutoff increases specificity at the cost of lowering sensitivity. So as you can see here, going from 37 as a cutoff to 1,000, the specificity will go up to 100%, but the sensitivity will go down to 41%. So in terms of imaging, the ultrasound usually the initial test to assess biliary obstruction. It's high sensitive, approaching to 100% detecting the intrahepatic biliary duct dilation, but it's very low yield to detect stricture themselves or masses. So follow-up cross-sectional imaging usually is required. CT scan is the most commonly used as a cross-sectional imaging modality, and it's excellent differentiating resectable and unresectable tumor, assessing the location and the contact with abdominal vessels. It has suboptimal sensitivity for detection early tumor or differentiating benign from malignant stricture in the absence of focal mass. MRCP is actually an invasive alternative for ERCP for diagnosis of biliary disorder. Usually, typical benign stricture is short, regular margin with symmetric narrowing, while malignant stricture usually longer, more than 10 millimeter, asymmetric with irregular margin. And MRCP itself has sensitivity of about 91 to 100% to assess the size and extent of biliary stricture. So biliary stricture associated with a mass lesion found in cross-sectional imaging, whether CT scan or MRCP, are best evaluated with endoscopic ultrasound to consider fine needle core biopsy or fine needle aspiration. And this also was according to the guideline from ACG guideline from 2023. So now, what is the role of ERCP in diagnosing biliary strictures? So in ERCP, there are certain cholangiographic features that are suggestive for malignancies. Longer length of strictures, abrupt transition point, irregular margin, shelf-like appearance, or asymmetric narrowing of the strictures. All these criteria representing malignant strictures. So the two cholangiographic pictures on the left are example for malignant strictures. The first one from the left showing abrupt transition point and shelf-like appearance in a patient with cholangiocarcinoma, and the second one showing also malignant structure affecting the common hepatic duct with apple core appearance as well, consistent with malignant strictures. And the other two showing more benign strictures, you can see the smooth concentric narrowing and dilation of the biliary tree proximal to the ampulla, which could represent ampullary stenosis. So nowadays, in a patient with biliary stricture, cytology is often performed during therapeutic ERCP. It's usually safe, does not need special expertise, and add little to the cost of ERCP. So it's the initial method for pursuing a diagnosis in patient with biliary strictures. It's usually done under fluoroscopic guidance. It's very high specific. The problem is that sensitivity is not that good. So usually between 30 to 50%, depending on what trial you're recording. The other modality for tissue acquisition is fluoroscopy-guided forceps biopsy. So usually they obtain tissue from biliary stricture by using biopsy forceps directed to the site of the stricture using fluoroscopy. And the difference between this and brush cytology, it provides a sample, it gives you a chance to get a sample of the subepithelial stroma that's usually not sampled by brush cytology. And theoretically, it can diagnose a subset of cholangiocarcinoma that do not project into the biliary lumen and only affect the subepithelial bile duct wall. It's technically more difficult, high risk profile, and less widely used. There's also special wire-guided biliary forceps that are available in some centers that can be used to get the forceps biopsy. So it's seen that the sensitivity of tissue sampling technique for prediction malignancy improve when different modalities are combined. If you see here, the brushing cytology has sensitivity of 23 to 56% with high specificity of 95%. Fluoroscopy, slightly higher sensitivity, 33 to 65 with specificity of 95. When combining both, the sensitivity goes up to 60 to 70%. So cholangioscopy, this involved passage, like the spyglass, this involved a passage of choledicoscope through the working channels of the duodenoscope into the biliary tract and provide direct, not only fluoroscopic, direct visualization of the biliary tract. And the visual finding itself has sensitivity of 88.9% with a specificity of 97.6%. When you take a target tissue biopsy, this will increase the sensitivity to 71 to 100% with also a specificity to almost 100%. Intraductal ultrasound is also another technology that can be used during ERCP. Ultrasound probe is advanced through the working channels of the duodenoscope into the biliary system, and it gives you real-time imaging of the strictures using high-frequency ultrasound and identify the malignant characteristic, including the hyperechoic asymmetric wall thickening and irregular border or broad shoulder. It also has good sensitivity and specificity, and also give you the chance to take biopsy under ultrasound guidance. Confocal laser endomicroscopy. This is also a novel endoscopic technology. It gives you a real-time histopathologic diagnosis of biliary strictures. Is also a mini probe that passed through the ERCP catheter, and after putting some fluorescein dye, you can see high-resolution images. It helps to differentiate between inflammatory and malignant strictures on the basis of two validated criteria, not for discussion on this lecture today, but usually it's reserved for indeterminate strictures after doing even spyglass or intraductal ultrasound. So now, after diagnosis, what's the role of ERCP in management? So the main goal is drainage. So this is the principal objective, restoration of bile flow into the duodenum. There is substantial variability in the difficulty and risk achieving adequate drainage, depending on the location and complexity of the strictures. For example, compared with extrahepatic stricture, the drainage of perihilar stricture is more technically challenging and riskier. The goal overall is to alleviate the symptoms when present, and also provide good quality of life, such as improved appetite, energy, and sleep. So after endoscopic, after cannulation and endoscopic sphincterotomy, the crucial step is to overcome the stricture with guide wire. Talking now about the benign biliary strictures, for example, the post-operative stricture, this step can be difficult sometimes, even if it's short stricture or short stenotic tract, can be asymmetric or ungulated and rich of fibrous tissue. That's why there are different characteristics of wire tip: straight, tapered, or J-shaped wire. But overall, like straight or J-shaped catheter guide wire can be good enough to pass the area of strictures. And sometimes you may need to do some maneuver like inflated stone extraction balloon just below the stricture to straighten the path and allow the wire to go through the area of strictures. So after passing the guide wire, there are three different interventions that can be done. Dilation is the first thing. So most of the time is a complementary technique before stent placement and rarely as a single method, except for primary sclerosing cholangitis. This is a main indication for dilation alone when dominant stricture are present. And actually, there was a study looking at the difference between stent placement or a short stent placement and balloon dilation in patients with primary sclerosing cholangitis, and showed that short-term stent not superior to balloon dilation and was associated with significant higher occurrence of adverse event. And also some study shows higher risk of ascending cholangitis with a stent compared to balloon dilation. Okay, the second intervention that can be done is plastic stent. Placement of single stent result in inadequate long-term solution most of the time, and that's is not recommended, especially in very narrow condition, narrow condition, due to their limited stent diameter and usually single stent have only short-term patency rate. So the other modality that was described is multiple stent strategy. And for this, you need to do a repeated ERCP every 3 months to exchange the stent and upside the number of, for example, 10 French stent that can be placed over a period of time of 12 months. to ensure that you have a good end result. This table showed multiple studies looking into benign biliary strictures and summarized the outcome with multiple plastic stent, and overall there's good outcome. So now, in the last decade, there has been increasing interest in the use of fully covered self-expanding metallic stent to treat benign biliary strictures. Usually, it's easier and faster to place and exchange than putting multiple plastic stent. It has greater radial force after initial ERCP, does not require multiple ERCP, and also has advantage that it has advantage of it gets a faster response compared to plastic stent. So this is a trial that was done in US, including over 100 patients with benign biliary strictures of various etiologies, and compared the fully covered metallic stent and multiple plastic stent, and showed that fully covered metallic stent was non-inferior, and the result was faster in terms of time and a fewer number of ERCP required, but no difference in the recurrence or adverse event. So the most recent guideline from ACG recommend that fully covered metallic stent, they prefer fully covered metallic stent over multiple plastic stent to reduce number of procedure and ensure good long-term effects. However, there are some exceptions. So when the stricture is very close to the hepatic ileum, you want to avoid the metallic stent. If the gallbladder is present and it's difficult to avoid the cystic duct, also it's recommended to use the plastic stent. If there's previous migration of metallic stent or the previous failure of metallic stent. So what about resectable malignant biliary strictures? So early studies showed that placement of common bile duct, either endoscopy or PTC before the surgery may have some benefit. However, most recent studies showed conflicting results. And this is a meta-analysis of 3 randomized trials and 22 retrospective studies, and showed that preoperative drainage associated with increased complication overall and increased wound infection specifically, but no difference in mortality and pancreatic fistula or intra-abdominal abscess. So the conclusion is that routine preoperative biliary drainage is not really recommended. There are some exceptions if there's evidence of cholangitis, if the patient is severely symptomatic, like severe pruritus, if the bilirubin is very high, over 250, if there is plan to do like neoadjuvant chemotherapy, of course, and if there is an expected delay in the surgery, usually more than 2 weeks. If these are the situation, then you may consider putting a self-expanding metallic stent. So what about if the malignant stricture is not resectable? Then biliary drainage is indicated. So the question, should we choose metallic stent versus plastic stent? So metallic stent is the primary stent used for malignant strictures. And this study comparing the 2 types of stent and showed that metallic stent has better patency period, a lower reclusion rate, and lower rate of cholangitis. And actually, these results have been duplicated in various other studies as well. So the role of plastic stent in this condition is very limited, and you may consider it actually if the life expectancy is less than 3 months. So we agree that the metallic stent is the preferred option. So should we go with uncovered or fully covered? There are multiple studies that have compared the both type of stent with conflicting conclusion. This meta-analysis compared both type of metallic stent and showed that the fully covered was associated with longer stent patency and stent survival. There was another randomized multi-center study that showed higher stent migration and earlier stent occlusion with the fully covered. And there's also theoretical risk of increase of cholecystitis with fully covered. So the evidence is insufficient to recommend for or against uncovered versus fully covered placement so far. Unresectable hilar malignant strictures. So endoscopic planning for optimal liver drainage is very important. We use a bismuth correlate classification, to assess the hilar strictures. So we have type 1 to type 4. And it's very important for us to know the anatomy, like the biliary drainage, the anatomy of the drainage for the liver. And in general, the right lobe usually drained by the right anterior and right posteriors, but also divided the section 6 and section 7 drain about 30%, section 5 and section 8 drain about 30% through the anterior right hepatic, and the left lobe, which include section 2, 3, and 4, drain about 30% of the biliary secretion, and the other 10% is from section 1, and it's actually combined both right and left. Knowing that is important because the goal overall is to drain at least 50% of the non-atrophic liver. So you need to know your anatomy. So what type of stent? So either plastic stent or uncovered stent, both were described and well established in patients with hilar malignant strictures. Fully covered stents are generally avoided, giving a risk of obstruction of the contralateral bile duct or side branches as well. So other modalities that are becoming more popular recently, intraductal radiofrequency ablation. And it's a novel palliative approach for unresectable malignant biliary stricture. It involves thermal energy to stricture, leading to necrosis and cell death. There are two RFA catheters available in the market, Habib Endo bipolar radiofrequency catheter and endoluminal radiofrequency ablation by Taiwan. These catheters can be advanced through a guide wire toward the target lesion and during the ERCP. The two main indications, palliative treatment for obstructive symptoms and ablation for metallic stent tumor ingrowth. It actually can be used for biliary stricture sometimes as well. So in conclusion, understanding the nature, morphology of the bile duct structure is mandatory before ERCP. During ERCP, performing both brushing and biopsy increase the diagnostic yield. Laryngoscopy plays a crucial role actually nowadays, diagnosing biliary strictures. Biliary stent should be chosen on the basis of the pathology and type of strictures. Balloon dilation remain the mainstay endoscopic management in PSC. Routine preoperative biliary drainage is not recommended for resectable malignant biliary strictures. Hilar stricture can be very challenging. MRCP is needed before ERCP to visualize the biliary anatomy and plan appropriate treatment to ensure at least 50% drainage as discussed. Thank you very much.
Oh, okay. Well, thank you so much, Ibrahim. You may stop your share. As a matter of fact, we can just give. You can actually also show your videos. Please open the cameras as we're gonna discuss some questions that are posted by the audience. May I have you on board, Ibrahim, Dr. Nawaf? Is there any chance you can unmute yourselves and turn the videos on? Dr. Nawaf, let's see how can we display that. There we go. I see you, Ibrahim. Dr. Nawaf.
It's on.
Okay. So I think all of us are on right now, if you can see us as well. So basically, let me do one more thing. Speakers, no. See that. All right. So basically, first of all, Dr. Nawaf and Dr. Ibrahim, thank you for the great presentation. As a matter of fact, I have one more or two more questions I would like to share with the audience and see their feedbacks, and then we're going to answer the questions before we move to the topic by the company. So I'm going to ask this question. The question says, this is for our dear audience, how long can you usually leave the plastic stent in place before the need to remove or exchange them? Now, you have 3 months, you have 6 months, and you can leave them as long as they are working with no problems. Seems like it's quite moving fast, and apparently, okay. So another 5 seconds before we. Answers are still coming. Okay, so we're gonna just share the results. So as you can see, basically most of our attendees chose to go with the 3 months, maybe 2 to 3 months, less 6 months, and the least can leave them as long as they are functioning. Dr. Nawaf, what's your take on this? And I'm gonna take Dr. Ibrahim.
Yes, the longer time you keep for plastic stent risk of cholangitis. So the recommendation should not exceed more than 3 months.
Ibrahim?
Mute.
Oh, you're Dr. Ibrahim, you're on mute. Sorry.
Okay, sorry. So it has been described like in the literature, like usually they can use the plastic stent 3 to 6 months, but personally, I think 3 to 4 months is the maximum, and usually bring patient at 3 month, 4 month mark.
I totally agree. I totally agree. So the reason behind this, yeah, definitely 2 to 3 months. And the reason behind this, these plastic stents having a biofilm that prevents the debris, sludge, as well as bacteria to grow. But that biofilm wears off in a matter of 2 to 3 months, which allows sludge and stones to start accumulating within the lumen of the stents, leading to the obstruction and failure. And that's the case. We have to be very proactive. I mean, sometimes they actually even block before that time, but if they stay in place, functioning well, plan your procedure to remove or exchange them within 2 to 3 months maximum. And that's excellent. So the second question before we go, the question is, you can see it, in case of benign biliary stricture with biliary obstruction. Now, again, with biliary stricture, because stent is not indicated unless if there is biliary obstruction, what's your choice for the metallic stent you're gonna place? Would you place uncovered, or partially covered, or fully covered? And we're gonna know exactly why. Answers are coming along. Really good. Again, the use of metallic stents usually because they have a better patency, they can last for a longer period, and actually they may actually remodify and help get that structure better in terms of patency. So I'm gonna end the poll here and share the results with you. So 55% of our audience, those answered the question, actually say go with a fully covered. Less with partially covered, the least was uncovered. Dr. Ibrahim, what's your take on this?
So yeah, for benign biliary strictures, my first option will be fully covered, of course, because you want to avoid having the uncovered stent, so which is not removable, and that can complicate things. But fully covered is the way to go.
Absolutely, Dr. Nawaf.
Yes, I agree. It's for benign structure, you have to go for the fully covered.
Absolutely. So again, the reason we place fully covered instead of partially covered or uncovered, basically because the mesh of the stent is completely sealed from the adjacent tissue, which, as you may know, it may result in ingrowth or ingrowth through the mesh, which will anchor the stent and make it much more stable and permanent. You will have a lot of work to do to get those stents without trauma out of the body. That's why if we plan to remove those stents in a period of whatever, 6 months, 3 months, 4 months, you name it, you better place a fully covered metallic stent, which can be removed easily. Now, that comes also with the risk of having overgrowth. Overgrowth, that means the tissue grows above and distal to the stent phalanges, which will cause also the stent to be difficult to be removed. That's why we don't recommend leaving them for a long time unless if you survey and follow them. Okay, so now we move to the questions that we have from the audience. The first question, basically, I think it goes to Dr. Nawaf. From Dr. Mazoun Al-Atabi, saying, are there any specific complications regarding balloon dilation or stones? She means balloon sphincteroplasty.
Yes, the risk of pancreatitis is there, and but the literature showing risk of the pancreatitis is low if you decide to do a limited sphincterotomy followed by large balloon dilatation compared to extended sphincterotomy or large sphincterotomy. So the risk is both in this maneuver. Also risk of bleeding, but it's considered as low. The other is perforation. So you have to make sure you use CBD diameter. You should not exceed the CBD diameter. So if you exceed it, there is a risk of perforation. So here the message, the balloon dilatation should not exceed the CBD diameter.
Absolutely, that's correct. The second question goes to Dr. Ibrahim from Afaq. Dr. Afaq Ahmed, he's asking for malignant biliary stricture, where metal stent is planned, should a plastic stent placement will benefit from the stent patency? Like, would you place a metallic stent, then through that stent you place a plastic stent, Dr. Ibrahim?
So since it's malignant, so I assume the choice was for uncovered metallic stent. I wouldn't do this as preemptively, but you need to consider that there's also chance that will be tumor ingrowth, and that will cause obstruction as well. So if that happened, then you may consider doing a stent over a stent, but I wouldn't do that preemptively.
Yeah, I totally agree. And now Raed is asking, Dr. Raed is asking how to approach intrahepatic stone, Dr. Nawaf.
So for intrahepatic stone, if your balloon or basket could not reach it, so the second option, you have to go by colonoscope assist lithotripsy, or sometimes you can go by colonoscope and catch by basket through the colonoscope. So that's only the way to extract the intrahepatic stone.
Absolutely. Dr. Ibrahim, do you have any add on that answer?
No, not really.
But for me, I usually go with if absolutely, as Dr. Nawaf mentioned, if I couldn't really get it through the basket or kind of sweep it out, I would definitely, my second choice, and I have a lower threshold to do that, is to use a colonoscope to selectively cannulate that area of interest and better manage the stone and make sure that nothing else is hiding in the ducts. Absolutely, that's a good. And the last question from Dr. Afaq as well. I think yes, I'm sure I'm missing that. DASE, is that metallic stent? Okay, so the question, the second question goes, what will you prefer in terms of EOS guided drainage versus rendezvous ERCP? I think this is the question for everyone, whoever is interested. Would you go with EOS guided drainage versus rendezvous ERCP, likely with the help of maybe EOS or our colleagues in intervention radiology? Any takers? I personally, yeah, go ahead, Dr. Nawaf.
Yeah, if he's talking about a malignant, if you fail to do an ERCP, in our center, we are going by EOS guided rendezvous. If patient is resectable, so we have to go rendezvous, or at least is integrate if patient is resectable. If patient is not resectable, so we have to go by duodenoscomy. Usually, this is our approach. We rarely refer cases to interventional radiology.
Dr. Ibrahim, that's the last last answer. Then we go to our colleagues.
I agree. I mean, if the patient is candidate for choledochondrostomy, you can do EUS, and if you have good dilation of the bowel, that you can do it at the same procedure, basically, if you fail to cannulate with the ERCP.
Absolutely, I wouldn't add any more. And then next we will move to Jannat al-Arab. Our dear Amr has a PowerPoint presentation. Amr, you can share the screen and proceed. After that, we'll be preparing for the live case. Will be moderated by Dr. Nawaf and Dr. Ibrahim, and then we will be happy to answer any questions live. Amr, you may share your screen if you wish.
Yeah.
Yes, you have your presentation?
Yes, it's is it clear now?
See if I can get you up. I think you should be able to do it. Able to do it. Amr, yes, that's your video, but can you share your screen?
Yeah.
Hit share. Waiting for you, Amr.
I'm sharing the screen, but
You're sharing?
yeah.
Well, let's see. I'm not sure, but I think try again, because I don't see your screen.
Okay.
Okay, that's your screen, I guess. Now,
Yeah.
there we go.
Okay. Perfect.
Okay, make it bigger.
Okay. Perfect. First of all, thank you. It's an honor to join the Endo Orbit event today. We believe that the Endo Orbit is adding a great value on the educational and scientific field for the gastroenterology society in the region. On behalf of Martin, the head of sales and marketing of ELA, we would like to present this presentation. Represented by Jet Medical in Saudi Arabia, ELA is operating since 1986 until now, developing unique products for the metallic, especially in the metallic stenting area, for the HCPs and facilitating new tools to help our patients. We have been operating in many countries, mostly in Europe, for more than 30 years, and the company is 100% Czech Republic company. If we're going to start with our two unique products, which are the biodegradable stent and the Danish stent. Danish stent is a completely fully covered esophageal stent. Is used for the acute variceal bleeding. It comes with a device or preloaded in a device that can be implanted totally blind without scope if the bleeding is acute. On the other hand, the biodegradable stent is indicated for the refractory esophageal stenosis with repeated dilatation failed. Usually, the biodegradable stent stays in the human body for 3 to 4 months. This obviously reduces the number of intervention and hospital visits. Also, it's intended for the patient aged 18 years old or older. And again, it's for the refractory esophageal stenosis. The biodegradable stent is also offered